Respected Chairperson, sir, dear friends, it's always been a very good pleasure and privilege to be a part of PTCon, and I thank Dr. Amitav Vishwas for inviting me out here in these difficult times we are going through, and also I congratulate his excellent team headed by Rajan and Amartya for showing for putting forward an excellent academic feast over this weekend. So I will be discussing about approach to gynecomastia. Let's start a little bit of history. Though controversially, it has been said that the pharaohs of the 18th dynasty of Egypt suffered from gynecomastia, and the cause that has been controversially attributed for that gynecomastia was familial aromatase excess. With this, let's come to business. What is gynecomastia? Gynecomastia is defined as the presence of palpable breast tissue, which is usually more than 2 centimeters, in males. And it is clinically significant when the breast is diameter exceeds 4 centimeters. But studies have shown that over 30% of normal military recruits had 2 to 4 centimeter gynecomastia. And in another study, in hospitalized patients aged more than 45 years, up to 70% had gynecomastia. Therefore, the question arises that we tend to think gynecomastia, yes, it's a very common endocrine abnormality, but whether it is normal at some such phases of life, and whether it is always benign. When we are confronted with gynecomastia, we need to differentiate it from another common mimicker, that is pseudogynecomastia or lipomastia. Now, as I said, in 3 phases of life, gynecomastia may be considered as physiological, that is neonatal gynecomastia because of transplacental passage of estrogens and progestins. Adolescent gynecomastia, about which I'll come in details later, and gynecomastia of aging. Because it's very common, maybe present in 70% of elderly individuals. But just because it is common, is it normal or physiological? We don't know. The gynecomastia of aging may be actually a manifestation of subtle endocrine or metabolic derangements. Now, what's the underlying pathophysiology of gynecomastia? In very simple terms, it is the imbalance between estrogen and androgens at the level of the breast tissue, a state of absolute or relative hypoandrogenemia and relative estrogen excess. The etiology that we all know, Klinefelter syndrome, is the typical example of hypogonadism with gynecomastia, but then there may be many other causes, including many common and rare drugs being implicated in causing gynecomastia. In some cases, we are aware of the mechanism. Some drugs like isoniazid or digoxin have estrogenic properties. Therefore, they can cause gynecomastia. Some of the anti-androgens like finasteride can cause gynecomastia, and a host of drugs cause gynecomastia whose mechanism is unknown to us. Now let's come to puberty gynecomastia. Usually begins at around 10 to 12 years of age and peaks around 13 to 14. 2/3 of patients will present with bilateral gynecomastia, but unilateral or asymmetric gynecomastia also can occur. The peak incidence is around stage 3 or 4. Usually regresses within a couple of years and generally In less than 10% cases, that gynecomastia persists beyond an age of 18 years or at the best 20 years. 50% may have a positive family history, again pointing to some subtle endocrine or genetic abnormalities. And there is another entity called pubertal macromastia, where there may be female appearing tanner stage 3 or 4 breasts, where spontaneous remission beyond 18 to 20 years is unlikely. But having said that, in a particular study, in only 7 out of 60 boys with pubertal macromastia could any endocrine abnormality be elucidated, endocrine abnormality or systemic disease be elucidated, again taking us nowhere. We do not know the actual cause of this, even this pubertal macromastia. Various hypotheses have been proposed. One may be a variable aromatization in these individuals, or higher expression of estrogen beta receptor in the breast stromal cells, because estrogen receptor beta are more efficient signal transducers than estrogen receptor alpha and estrogen receptor polymorphism itself. With this basic pathophysiological background, let's come to the evaluation of gynecomastia. When an endocrinologist is faced with a patient or an adolescent with gynecomastia, we have to answer some questions. First, whether it is true gynecomastia or lipomastia. Second, if it is gynecomastia, is it physiological or pathological? If it is pathological, what may be the probable etiology, and whether the etiology is a benign one or a sinister one? And lastly, whether the patient is psychologically disturbed by the gynecomastia. To answer these questions, we have to ask some questions to the patient. What is the rapidity or tempo of breast enlargement? Whether the enlargement is asymmetrical, whether there is any pain, tenderness, hard mass or fixity. Because a rapid enlargement, asymmetric enlargement, pain or tenderness point towards a malignant process. So, the detailed history is very important, and one should seek history of virilization, seek history of other feminizing symptoms, any nipple discharge, nipple retraction, any history suggestion of systemic illness like chronic liver disease or chronic kidney disease. But what is very important is the drug history, because of most of common and rare drugs can cause gynecomastia. And also a family history, because as I started my lecture with, diseases like familial aromatase excess run in families. Now, how do you examine the breast? This is the way we should examine the breast to find out the breast disc and measure the disc diameter, because the dimension of the breast disc has some connotation on the pathophysiology or etiology of gynecomastia. Apart from examination of the breast, a thorough and thorough examination is needed, especially examination of the genitalia for the sexual maturity ratings, other anthropometric indices, any other symptoms of feminization, and any asymmetric enlargement of the testes or any swelling in the liver, like suggesting a testicular tumor, and liver tumor, so on and so forth. Now, grading of gynecomastia, this is the Simon, Hoffman and Hahn gynecomastia classification. We endocrinologists do not use it much, but it is popular with the surgeons because this classification aids them in taking surgical therapeutic decisions. Coming to the laboratory investigations, the laboratory investigations should be directed in finding out any chronic systemic illness that can lead to gynecomastia, like liver disease, kidney disease, and then thyroid disorder in thyrotoxicosis or hyperthyroidism may be associated with gynecomastia in around 6 to 10% cases. Then other hormonal examination investigation should be done to detect the hyperestrogenic state or hypogonadism. But a word of caution, when you do the estradiol assay, the commercial immunoassays are notoriously inaccurate at low concentrations. If you suspect an HCG secreting tumor, you have to use the beta HCG assay, but you should use monoclonal antibodies that detect all forms of intact HCG and free beta HCG supplement. So this is the diagnostic algorithm. The evaluation should start with history and physical examination. We should differentiate whether you are really dealing with gynecomastia, so what is the working diagnosis of etiology. Then, of course, we should advise appropriate biochemical investigations to derive the diagnosis. Imaging is generally not needed for diagnosis of gynecomastia, which is essentially clinical, but at times a sonomammogram may help to find the breast disc or better delineation of the breast disc morphology. If you suspect a scrotal tumor, you have to do a scrotal USG or appropriate imaging to uncover an adrenal neoplasm or a hepatic neoplasm. Again, tissue biopsy or histopathology is not needed in most cases for diagnostic confirmation. However, should a histopathology is done, gynecomastia is characterized by proliferation of duct tubes without terminal acidine in a fibroconnective stroke. Coming to the treatment depends upon the cause, treatment depends upon the situation. In many cases of pubertal gynecomastia, masterly inactivity with reassurance may be the only treatment needed. We have to explain to the patient and the parents that in about 80 to 90% cases, a pubertal gynecomastia will subside on its own by age 18 to 20, so nothing needs to be done, but the exception would be the condition of pubertal macromastia, where some cosmetic treatment may be needed. If you have to use some pharmacotherapy of the many agents available, at this point of time, tamoxifen appears to be the drug of choice. The dose is 10 to 20 milligram daily for 3 months or so. Tamoxifen has the largest body of evidence with a long period of follow-up. It causes good pain reduction, reduction in breast size, prevention of recurrence, and has no effect on somatic growth. But medical treatment is generally ineffective if the gynecomastia is of more than 1 to 2 years duration, where there is considerable fibrosis, and you have to consider surgery if the patient is very much disturbed, and reduction mammoplasty sparing the nipples or preserving the nipples is what the surgeons mostly practice. Similarly, in adult gynecomastia, many a time, masterly inactivity is the treatment if that is appropriate. One should try to find out any underlying cause or any incriminating drugs. For example, if androgen deprivation therapy is being used for carcinoma prostate, then we cannot stop that. There also reassurance and maybe radiotherapy may help. Again, tamoxifen is equally effective in adults, and with a persistent disfiguring gynecomastia, cosmetic surgery may have to be taken help of. To conclude, therefore, when we endocrinologists encounter patients with gynecomastia, first we have to differentiate that gynecomastia from lipomastia, that at many times, most of the times, is an easy clinical exercise. You do not have to do a mammography or sonomammogram for that. That can be decided clinically in most of the cases through a thorough physical examination. Then to differentiate physiological forms of gynecomastia from the pathological ones. Next, to differentiate the innocuous pathological forms of gynecomastia, like that due to pubertal changes, that is puberty gynecomastia, from the more sinister ones as caused by an HCG secreting tumor. So try and find out the etiology and the pathology variants and address the same if possible. So if the underlying cause is a feminizing tumor, that has to be removed. And to assess, that's very important part, to assess the psychological impact irrespective of etiology. Many adolescent boys, despite having what we understand is a simple adolescent gynecomastia, may be so disturbed psychologically, hampering their studies, hampering their social life, that we have to offer them some sort of treatment in the form of liposuction or even reduction mammoplasty. So treatment strategy needs to be designed accordingly, according to the psychological needs of the patient and also the medical needs of the patient and the comorbid clinical situations. So to conclude, I've given you an overview of gynecomastia, and I thank Dr. Amita Vishwash once again to allow me to select a topic of my choice in the diabetes conference, which does not directly relate to diabetes. And as I have already referred to the 18th dynasty of Egypt, there have been a few other instances, historical references to gynecomastia, that is the refeeding gynecomastia that was observed in the liberated prisoners of war after the Second World War, and also the epidemic of gynecomastia that occurred in the Haitian immigrants to the United States because of use of delousing agent in DDT, which is an estrogen mimic. So these are very interesting snippets of gynecomastia from the recent history. With this, I conclude. If you have some questions, I would be happy to address them.
So thank you, Dr. Nilanjan Sengupta.